Our next speaker is Dr. Bagatell. She's a pediatric oncologist with expertise in the care of children with solid tumors, particularly neuroblastoma and sarcomas. She is the solid tumor section chief at the Children's Hospital of Philadelphia and professor of pediatrics at Perelman School of Medicine at the University of Pennsylvania. She is the current vice chair of the Children's Oncology Group Neuroblastoma Committee. She did her internship and residency at University of Arizona in Tucson, her fellowship at University of Arizona, and Children's Memorial Hospital at Northwestern in Chicago. As a member of the Children's Hospital Oncology Developmental Therapeutics team, she is involved in research studies, clinical trials of new agents for patients whose cancer don't respond to initial or established treatments. She and her colleagues conduct research trials that provide patients access to the newest anti-cancer medications, and her presentation today is an update on the current COG trials being conducted and any study results of past trials. Dr. Bagatell.
Thanks so much, Pat, and thank you to everyone who's here this morning. I'll be talking about COG trials, and I think I left plenty of time for questions at the end. Can you switch the slide deck? Oh, it's not coming up for me, but I guess it's coming. Okay, fine. All right, great. So I think many of you know what the Children's Oncology Group is, but I thought I'd just start out by explaining, maybe contrasting a little bit with Europe and just making sure everyone's clear on what COG does and doesn't do. So the bottom line is the top line, I guess. The Children's Oncology Group is an organization of more than 225 hospitals around mainly the U.S. and Canada, but a few other sites around the world that come together to conduct clinical trials. And the genesis of this was really that while plenty of hospitals in this country and the other countries that participate have a lot of experience in taking care of children with neuroblastoma and investigating neuroblastoma, no one center can solve the problem alone. And so there's a long history of collaboration. Just as Gudrun explained about Europe, there's a long history of collaboration on this side of the ocean so that we can come together and develop and run rigorous clinical trials that can answer the most pressing questions that we have. So we do have sites in Australia, New Zealand, and Saudi Arabia, but most of the institutions are in North America. Unlike SIOPEN that Gudrun just talked about, the Children's Oncology Group is primarily funded by the National Cancer Institute. And so there's a lot of oversight of what the Children's Oncology Group can do by representatives of the people who pay for the trials. So not every question that we would like to answer as investigators and that you would like to answer for your children can be answered with the budget that we have and with the oversight that we have. That being said, it's a huge investment on the part of the National Cancer Institute in our research, and we're very grateful for that funding. We hope it continues. The Children's Oncology Group is not a neuroblastoma-specific organization. So in the COG, there are different disease committees and different disciplines. So there's a leukemia committee, there's a renal tumor committee. There are a lot of competing demands among the different pediatric cancer investigation groups. There are also different disciplines, so there are radiation oncologists, surgeons, people who are interested in epidemiology, patient-reported outcomes. So it's almost like a matrix kind of organization with the disease committees and then the different disciplines working together. So what does the COG Neuroblastoma Committee in particular do? Our mission is to conduct trials designed to be practice-changing. And that's really important because there's so many questions we want to ask. And I, like everybody else, sometimes go down a rabbit hole and I get really interested in something and want to figure it out. But then we have to bring ourselves back to reality and say, are the questions that we're able to ask with the funding that we have really going to change how people practice medicine and care for children with neuroblastoma? So that's always kept in mind as we think about all the ideas that we want to bring forward. The next important point is that we want to not only conduct trials, but we want to facilitate the understanding of neuroblastoma biology. So I think Gudrun really gave you the flavor of how they're attempting to do that in Europe. In COG, we have a much more streamlined system because we send our clinical samples for patients enrolled on trials to a central lab, and much of the analysis is done by the same group with the same platform, so there's a lot less trying to merge the different testing platforms together. So that's really great. And then that information from the central sequencing and central analysis can be distributed to investigators throughout COG and throughout the world if there are approved requests that are sent in. In addition, we have a big biobank that's very well annotated with clinical information, and that is a gold mine for clinical investigators. So for many of you, somebody sat down at the time your child was diagnosed and said, are you interested in extra tissue from a biopsy being banked? And they may have explained the idea of a bank to you. It may have gone in one ear and out the other at the time, but the idea is to create this really highly annotated bank with samples that have information about age, stage, site of disease, all the other things. And then investigators who have a really great idea for a new biology study don't have to wait at their own institution for one patient to come in and then a few weeks later another, or a few months later another. You're never going to change the world that way. That's really slow. But with a biobank, you can write a request and say, I need 1,500 samples from over the years. I got this great idea for a project. Let's go through the process and get those samples. So that's one of the things that COG is really committed to, is making those biological samples available to investigators. And that's part of the development of new therapies. We also want to try to learn as much as possible from each patient. And so in addition to running clinical trials that have a lot of statistics associated with them and are broad and looking at groups of patients, the COG is also committed to going deep and trying to understand not only about the biology of the tumor, but also I'll talk a little bit more in a few slides about the patient-family experience, about late effects, and really try to improve every aspect of the care of children with neuroblastoma. The other thing that I want to mention, it's at the bottom of the slide, but perhaps it should have been at the top, is to develop the next generation of neuroblastoma investigators. So all of us came from somewhere, and as Pat mentioned, I grew up in Arizona. I'm not from Children's Hospital of Philadelphia. I'm not from the East Coast. I'm not from one of the big places. But the people who came before me took an interest in me and my interest in neuroblastoma, and so here I am talking to you today. So all of us came from somewhere. All of us were right out of training at some point, and now that those of us in a leadership position have the ability to do so, we're really committed to bringing along the people who are going to carry the research forward. And I'll talk about that in a few minutes as well. So I'll drill down now on some of our clinical trials and kind of give you an update on where we stand with things. So this is our relatively recently completed high-risk trial, ANBL 1531, near and dear to my own heart because I ran this trial with Steve Du Bois from Dana-Farber Boston Children's. It's a little bit of a complex slide, but the general idea is that all patients are diagnosed and receive their initial cycle of chemotherapy. And while they're going through that, we're doing some testing to determine some of the genomic features of the tumor. And primarily in this trial, this was testing for aberrations in the ALK gene, either amplification or mutation. And those patients were assigned to a certain arm of that trial where they were given an ALK inhibitor in combination with the rest of their multimodality therapy. And I know that some people's children in this room were on that particular trial. Patients also underwent an MIBG scan, and those patients whose disease did not light up on the MIBG scan were assigned to their own arm, which is on the left side of your screen, arm D. And then all the other patients who had no aberration in the ALK gene, but whose disease lit up on the MIBG scan, were randomly assigned to standard therapy that included chemotherapy, surgery, radiation, high-dose chemo with stem cell rescue, and immunotherapy, that whole thing, arm A, or that whole thing with the addition of MIBG therapy early on in treatment. So those were arms A and B, and patients were assigned not by me, not by Steve from Boston, not by any human, but by a computer, so that at the end of the day, we could say for sure whether the MIBG early in treatment made a difference or not. That study is now closed. The randomization was complete. Thanks to all of you who agreed to sign up for this trial. We are no longer enrolling patients on the randomized portion of the trial. The results are not yet available, the outcome results. Those will be available in October of 2026. So stay tuned. That's coming up sooner than perhaps we think. We didn't, during the course of the randomization that drove the whole duration of the trial, there weren't enough patients who enrolled on that arm on the far side of the trial slide, arm E. So that arm is actually about to reopen, thankfully. It's taken much longer than we ever wanted, but there will be patients who will come off of the trial I'm going to talk about next and fill up the rest of that arm E. Those patients will get the multimodality therapy with lorlatinib as soon as that trial that arm reopens. The frontline trial that is open right now, if a new patient walked in the door, they would be offered this trial ANBL 2131. And this again is a randomized trial. So we don't get to choose the arm, families don't get to choose the arm, and it's really an important concept that patients are assigned so that at the end of the day we can say they were matched based on certain characteristics and we can definitively say which treatment was better. I'll walk you through the top part of the slide first because there's a lot of boxes and arrows. But all the patients, again, come in, they get their first cycle of treatment, and on this trial, they're randomly assigned to a treatment that's either the standard therapy with chemotherapy, surgery, a little more chemotherapy, and then if the disease has really responded at the end of induction, those patients can then proceed on to get back-to-back high-dose chemo with stem cell rescue. So those boxes are the thiotepa cyclophosphamide, carboplatin, etoposide, and melphalan, abbreviated as CEM. Patients who don't have a fantastic response at the end of induction can then go on and get chemoimmunotherapy, so low-dose chemotherapy with an anti-GD2 antibody, and see if they get an improved response and can loop back and then move on to the rest of COG standard therapy. I didn't want to make the boxes too small, so I ended the treatment after the two back-to-back thiotepa cyclophosphamide followed by CEM, but you can see that the arrows keep going. Those children also get radiation, they get immunotherapy, they get cisretinoic acid, and other medications during the last part of therapy at the discretion of the treating physician. So that is the standard. The upper part of the diagram shows just the part with the randomization and the idea that if you don't have a great response, you can still get chemoimmunotherapy on trial, and then we can still continue along with the rest of the treatment. On the bottom part of the slide, you can see some Ds in circles, in blue circles on the bottom. The D stands for dinutuximab. Dinutuximab is an antibody directed at GD2, which is on the surface of neuroblastoma cells, and that was studied 25 years ago by Alice Yu and colleagues and shown to be of benefit in the latter part of treatment, the post-consolidation phase of treatment. And the investigators at St. Jude and elsewhere studied moving up the dinutuximab early in treatment and found that there's some really encouraging outcomes. And so this randomized trial is asking the question, if you move dinutuximab up earlier in treatment, is that better than giving standard treatment, allowing patients to get chemoimmunotherapy if they don't have a good response? Which is better, sooner or later? That's the primary question on ANBL 2131. I will say accrual enrollment on that trial has been really good. Families are very interested in this question, and the study team is doing a great job keeping patients moving through, providing guidance, and that study should finish accrual right on time in the next couple of years. We're already working on the frontline trial that will follow ANBL 2131. So one of the really big holdups in clinical trial work is having a gap between studies. if one trial finishes and you wait for those results before you open up your next one, that may take years. So I told you that ANBL 1531 is currently closed. We won't have the results till 2026. If we waited to enroll patients on a new trial once we had those results in 2026, it just really slows things down. So we are working currently to design and plan this frontline clinical trial that will finish right when 2131 ends, so that we can keep learning all the time. So this frontline trial has a number. We do catchy names here in COG. It's ANBL 2431, and it has a very similar induction regimen. Remember, we won't know the results of ANBL 2131 at the time that 2431 opens. So it's a standard COG induction. Those patients who have a poor response to therapy, as I mentioned before, can get chemoimmunotherapy and then loop back in right along with the patients who have a good response. And then comes the randomization, which is a really, really important one. And the impetus to ask this question came in part from investigators, but in very large part from families. So we listened, you spoke, and we listened, and I think the parent advocates on both sides of the ocean did an amazing job, like kind of kicking us in the butt and saying, you got to answer this question sooner than later. The question to be answered is whether in the immunotherapy era, do we still need high-dose chemo with stem cell rescue during consolidation? So the boxes on the top of the slide show thiotepa cyclophosphamide, carboplatin etoposide melphalan, that's the back-to-back high-dose chemo with stem cell rescue. And the boxes down below are chemoimmunotherapy. So low-dose chemo, irinotecan, temozolomide, combined with the anti-GD2 antibody dinutuximab, and that's the randomization. Can we give chemoimmunotherapy and even have equivalent outcomes, if not better, compared to high-dose chemo stem cell rescue? That question has been asked in retrospective studies, and it's a really hot topic, but no large multi-center study with a large number of patients has been asked to date where patients are randomly assigned so that the two groups are very similar, to know whether we still need to do high-dose chemo with stem cell rescue in the frontline setting. So we're really wanting to ask that, as I'm sure you are as well. In terms of relapse studies, so we in the COG have primarily focused on first relapse. There are a number of organizations, including NANT, that have focused more on patients with multiple relapses or disease that has not responded to therapy even after many, many therapies. So we kind of partner with the NANT, and COG has primarily focused on first relapse. And one of the most well-known trials that we conducted a number of years ago, Rajan Modi was the chair of this study, used a backbone of irinotecan and temozolomide, and patients either got the mTOR inhibitor temsirolimus or they received dinutuximab. And that study was actually closed early because the results from the dinutuximab arm were so much better than the other arm. And that's where this idea of using chemoimmunotherapy to improve outcome that you saw on the previous couple of slides really came from. So this was a really paradigm-shifting trial, and if you want to talk about practice changing, this was it. You know, patients who relapsed after the results of this study came out, almost uniformly in North America received irinotecan, temozolomide, and dinutuximab, whereas prior to this study, that just wasn't part of the treatment paradigm. So that was a huge win and a real difference maker, but even though a lot more patients than we thought responded to this therapy, it remains true that over 40% of patients with relapsed neuroblastoma, relapsed or refractory neuroblastoma, have disease that just doesn't respond to chemoimmunotherapy. And sadly, we cannot identify those patients ahead of time. It would be so much better if we knew who was going to respond and who wasn't based on our biology studies, maybe something about the surface of the neuroblastoma cell, maybe something more intrinsic to the neuroblastoma cell on the inside. We really have no idea. This is a huge area of investigation, and the fact that we don't know does not mean that people aren't trying. But at this moment in 2025, we cannot predict who's going to respond. And so on this slide, you can see a picture of a patient of mine whose scan showed obvious disease progression. Is there a Do I have a pointer? I don't know if I do. But anyway, on the left side of the slide, there's a big tumor in the abdomen, and you can see it's much bigger in the slide on the right. It has really grown tremendously despite everyone's best efforts to treat with chemoimmunotherapy. So we have got to do better for those patients whose disease does not respond. And so number of years ago, we developed the ANBL 1821 trial that's led by Meg Macy. And if you're sticking around for the actual ANR meeting, this is a plenary session on Wednesday at 10:15. So if you're here, please come and listen. This was a trial of irinotecan, temozolomide, and dinutuximab by itself, as you can see on the top line, compared with irinotecan, temozolomide, dinutuximab with the addition of eflornithine or DFMO. DFMO depletes polyamines in tumor cells and has been of tremendous interest, as you know, to the neuroblastoma community. And so we thought it was really important, based on laboratory work done by Mike Hogarty and others, to run a randomized trial to see if the addition of DFMO improves response. So Meg Macy will be presenting those data. I actually can't present them today because the results are embargoed until she presents them. But come if you can. So that trial is now complete. The results will be announced on Wednesday. A publication will follow very quickly, but we're not resting and waiting. We're continuing on and developing our next trial, which is ANBL 2421. And that is using a slightly different backbone. As I mentioned, a lot of patients are getting chemoimmunotherapy if their disease does not respond to induction or in other contexts. So a lot of people are already seeing irinotecan, temozolomide, and dinutuximab by the time they relapse. So what we've done in ANBL 2421 is to switch out the backbone to a different set of drugs, some of which Gudrun mentioned in her talk. On the Beacon trial, topotecan is a drug that many patients won't have seen since the very beginning of their treatment, and there's a pretty impressive response rate even in patients who have previously received topotecan and cyclophosphamide. So the backbone is a little bit different than what you saw on ANBL 1221, and there's a new agent that is being added. As you can see, the red bars are the new agent that we think will improve the immune response to the chemoimmunotherapy. This is still confidential because the company is still working with us to develop the trial, but I think the concept is more important than the specific agent, just that we're not resting and saying, yeah, irinotecan, temozolomide, dinutuximab is fine, even though up to half of the patients don't respond. No, we want to improve the immune response and improve the response rate. I'll move on a little bit to talk about some of the other areas of investigation. We are well aware that the therapy that we're giving is very complicated and very toxic for children with high-risk disease. This is a slide courtesy of Lisa Diller and Tara Henderson, who ran a study called the LEARN study, Late Effects After High-Risk Neuroblastoma Therapy. And what they found really shook us up. We were well aware that a lot of patients have hearing loss. We were well aware that there are growth issues for children who were treated for high-risk neuroblastoma. We knew that some patients have endocrine issues, but I think the scope of the problem was not really well appreciated until the LEARN study. And what we saw was more than half of the patients treated with the kind of regimen that we use in the COG required hearing aids. That is not a surprise to those of you sitting in the audience who have a child who survived this therapy and has hearing aids. But for others, I think it's really a much higher number than I think we appreciated before. The incidence of premature ovarian failure, almost a quarter of the girls will go on to have premature ovarian failure. I'm not sure we appreciated the extent of that issue as well. So as these data have become available, we've started to think, what can we do in the frontline setting to try to prevent some of these toxicities? We have excellent survivorship support at most of the institutions in COG, but once the therapy has been given, you can't take it back, and you can do what you can to try to decrease these toxicities after the fact, but wouldn't it be better if we could figure out what to do up front? So we've been really talking about toxicity mitigation, preventing the problem before it's a problem. And one of the ones we wanted to start with was an ototoxicity task force, so looking at how we could prevent hearing loss in these patients. And what we started with was really an interdisciplinary team of oncologists, audiologists, pharmacologists, and many others to try to think about how we could approach this. There was a key role for our COG parent advocate, Jen Bell, who was really a very important voice in, again, sort of kicking us in the butt and saying, you got to stop talking about this, you have to do this. So thanks to her for doing that. What we did was we went back and looked at the audiograms on patients on ANBL 1531, the high-risk trial that I just mentioned. And again, we saw this really impressive amount of hearing loss in those patients even before they got the high-dose chemo with stem cell rescue. So just from the induction therapy that they got at the end of induction, about half of them had clinically significant hearing loss. And Molly Taylor will present that on Wednesday. We stepped back and said, okay, what kind of otoprotection options are out there? And we evaluated everything from like injecting directly into the eardrum to try to prevent and protect the eardrum and the other components of the ear. That seemed like not that great an option in little kids. It's kind of tricky to have them go to sleep and inject their eardrums multiple times. It just seems a little nutty. So we moved on from that and looked at some other agents that you can give systemically. The other thing we did, though, at the same time as we were looking at these agents, is we asked one of our colleagues, Pat Reynolds, to look at what happens in neuroblastoma cells in the lab to make sure that we weren't just protecting ears, but also we didn't want to be protecting neuroblastoma cells. So that was a huge issue, and the agents that we narrowed it down to did not appear to protect the neuroblastoma cells. So when we exposed them to chemotherapy, they still died as a result of the chemo. So we came up with, together with our colleagues from the Cancer Control Committee and COG, we came up with a concept that's under review and certainly of interest. It's based on some data in the adult world, the adult head and neck literature. Some groups looked back at patients and found that those that were on statins when they were getting their treatment for their head and neck cancer had less hearing loss than those that weren't. That's a very astute clinical observation. So those investigators started to ask the question and run the trials of whether the use of a statin empirically could help prevent hearing loss. So that's one of the things, the most important thing that we're looking into. And Molly will probably mention that on Wednesday. The other thing we would like to do is to make better decisions about good response, poor response, how do we look at patients' disease better. And our current approach to disease evaluation relies on CTs, MRIs, bone marrow aspirates and biopsies, and MIBG scans. As probably all of you know who've ever had your child have to go through an MIBG scan, it's a 2-day procedure, inject one day, scan the next. The scans themselves, the time on the MIBG table, it can be very long. I had a patient who got through it the other day without sedation, which was so brave of her, but she was on the table for 2 hours, which is a lot to ask of a little kid. And I think all of you whose kid have ever gotten an MIBG scan knows that the thyroid protection drops are truly nasty. So we're very interested in new tracers that are associated with shorter scan time, no thyroid production, same-day procedure. And one of the ones that we've developed a concept and actually a full protocol for is MFBG imaging. That approach has been studied by a number of different groups in Europe and in North America. But what we would like to do is really understand how do the results of the MFBGs compare to the results of the MIBGs, and how does that change your response designation, your risk assignment? So there may be patients who thought that they had localized disease based on the MIBG, but whoa, now the MFBG picks up a new spot. Does that matter? Should we treat them differently? Or does it come out the same anyway? So these are some of the things that we need to do, and I think it keys into a little bit what Gudrun was talking about. When we have new technology, we're super excited to use it, especially if it improves people's quality of life. But we also need to know, what is it telling us, so that we don't just jump to conclusions and make uninformed decisions. So we've proposed, and this trial has been approved by the National Cancer Institute and others, and I hope that it will be opening soon. On the theme of better decision making, I'll move right into some of the biology work that I think could really inform what we do, and this ties back into that theme of trying to learn as much as we can from every patient. So this is a beautiful diagram that I borrowed from Meredith Irwin and Kelly Goldsmith's publication, but it just shows all the ways that we're looking at hosts, so the patients themselves, and tumors to try to understand what we need to do the same or what we need to do differently. So here are some of the things that projects from ANBL 1531 that we're currently working on. Kai Tan and his team is interested in single cell analysis, and you can see that in the picture we're looking at both the tumor cells and the immune cells. Kelly Goldsmith is also involved in looking at the host immune landscape from specimens from ANBL 1531 and other trials. Frank Bayless has been looking at circulating GD2 in blood samples, and that is certainly of interest, and Pat Reynolds has been looking at bone marrow samples. Pat and his group have also been looking at telomere maintenance mechanisms in tumor cells, and we're really looking forward to the results of how can we use these different tests and different pieces of information to make better decisions. As you'll see at this meeting, there's going to be a whole lot of COG data. So we have more presentations and posters at this ANR than we've ever had at any ANR previously. And I think it's in large part to the community of both clinical and lab-based investigators that we're able to be this productive and really learn from every patient. So Gabriela Verdzakova from Brian Crompton's lab is presenting a really nice plenary about ctDNA and what we've learned so far from ANBL 1531. There's also a poster looking at some other aspects of ctDNA from Mark Applebaum's lab on Sunday. Esther Burko, who will be speaking with you tomorrow, has been really involved in some retrospective and prospective studies of ALK status in neuroblastoma, and she presented this at the last ANR and will present it to you tomorrow. But her paper was just published looking at a prior high-risk study and the meaning of ALK aberrations in those tumors. We've also done a huge effort to look at DNA and RNA level profiling, and Kevin Ying from the Martis lab will be presenting that orally on Tuesday. So it's really a lot of work, and trying to make use of every single specimen and all the patient information that we can to try to make better decisions, develop new techniques to inform how we think about neuroblastoma. I almost forgot, sorry. There's also a really nice piece of work from Trevor Pugh's lab up in Toronto looking at host immune characteristics to try to understand, particularly in the context of immunotherapy, how patients might respond to treatment. So on the theme of learning as much as possible from every patient, we're doing some large-scale profiling efforts similar to what Gudrun described in Europe. This is done through the Molecular Characterization Institute that's funded by the National Cancer Institute. And what we hope is that this risk classification scheme that Gudrun also showed you and is outlined in a beautiful paper by Meredith Irwin could evolve over time. We could learn new things, new prognostic and predictive biomarkers could be developed from these large-scale efforts to try to risk classify better and assign treatment better. So that's a really big effort that we're making right now. In addition, we hope that the Molecular Characterization Institute will help us develop new small molecule treatments, medicines that you can take by mouth, and would target specific changes within the tumor cells. And then the lower figure is more about helping us understand how the sequencing and expression profiling can help us develop new immunotherapies as well. So that's really active work going on through the MCI and beyond. On that same theme, what we would also like to do is be a little bit smarter in our risk classification. So I haven't talked very much about low and intermediate risk disease today because mainly our focus and our energy has been on high risk disease because that's where the outcomes are just not acceptable. But these are some survival curves from Claire Twist's study from a number of years ago about patients with intermediate risk disease. And those top lines with 100% survival are awesome. But you can see there's a line down below in this Kaplan-Meier curve that isn't that awesome. And there are patients who have intermediate risk disease who do relapse and do go on to die from their disease. And we really don't have the right tools to identify those patients right now. And so we're currently working on a case control trial where we're using genomic information to try to develop new biomarkers specifically to pull those patients out and say, wait, you look like you have intermediate risk disease, but you actually have high risk disease and need really different treatment. So that's a work in progress. In addition, Pat Reynolds and others are trying to help us develop assays to try to use chemoimmunotherapy or immunotherapy in general a lot better. As I mentioned before, we still have no clue who responds to GD2-based therapies and who doesn't, and so Pat and his team are working very hard to try to help us identify that. In addition, we're really supportive in the COG of developing models, both cell lines and mouse models. So we really encourage sites in the COG to send tumor tissue, bone marrow, whatever they have, to Pat Reynolds' lab, and he has developed a very large and impressive number of cell lines for investigators to use, as well as the mice that you can see here. We also, as I mentioned, we're sort of a matrixed group, and so we really encourage research by our surgeons and radiation oncologists. And just an example of this is to answer a very straightforward question: how aggressive does a surgeon need to be when they take out a tumor? And Krista Grant is going to present that data on Monday. So we're very supportive of the surgical questions as well. We also have been branching into a new area of inquiry recently, and Kira Bona is giving a big keynote presentation on Monday that relates to some disparities and some interventions to address disparities in treatment. So this whole area of inquiry is called social determinants of health. And what Kira and colleagues found a few years ago is that children living in poverty have a worse outcome than children who are not living in poverty. And I think that was not well recognized in the neuroblastoma community. And I think it's kind of a dirty little secret that nobody wanted to look at, because we think that we treat all patients the same. We'd like to think that we do. But the data were there in black and white. And Kira has really delved into why that might be. Is it something about, I think microbiome came up a few minutes ago. Is it something about the environment of less privileged families? Is there something about other aspects of the treatment? But Kira has really led the way on this, and we're trying to learn more about it. Kira has also been very involved in interventions to try to address that problem as well. So we're trying to learn. We're also trying to learn about neuropsychological late effects of neuroblastoma therapy, both for patients who receive standard therapy and patients who are treated with drugs that have been associated with differences in neuropsychological outcomes. And we're also really interested in patient and parent-reported outcomes. Gudrun mentioned that in Europe, the Mona Lisa trial is looking at some parent response and trying to understand what the impact of ctDNA work is on parents' well-being, and we're adopting a patient-reported outcome approach in the ANBL 2431 trial. It seems like an obvious thing to think that if you're randomized to back-to-back cycles of high-dose chemo with stem cell rescue, that patients and parents might be more miserable with that than they would be with chemoimmunotherapy, but we don't actually know that, and we're really committed to hearing the parent and patient voice to try to understand that better. As I mentioned, we're trying to learn as much as we can about every patient. So there's going to be a couple different presentations about modifications to therapy. So Meg Macy will include in her presentation a little bit about hearing loss experienced by patients on 1821. And Emily Greengard will describe some of the outcomes that we saw in patients who got lorlatinib on ANBL 1531. Small numbers of patients had some very serious complications, and we need to listen to that and learn from that. Finally, I just want to go back to that point, COG's commitment to develop the next generation of leaders. Mentorship has always been important, going back to Audrey Evans and others. So I don't know if any of you have heard about this movie, Audrey's Children, but features Audrey Evans. It's really quite good and very inspirational. But Audrey not only did a lot for neuroblastoma therapy, but she was a role model for many of the people who are leaders in the field today. And the two people that are shown just below her sort of inherited that mantle. Sue Cohn and Kate Mathey trained many of us who are now in leadership positions, and we feel the responsibility to carry on that tradition as well. It's really important because there are workforce issues. Not as many people want to go into pediatric oncology as in the past for a variety of reasons. There's also a lot of concern about research funding right now. So we really feel like we need to commit to getting people started with their first projects, give them the opportunity to get hooked on neuroblastoma research, and then go on in their careers to lead trials and other sorts of things. And Ami Desai is going to speak next, but I think she's a perfect example of this, having led the ANBL 19P1 trial and now taking on other kinds of projects. We've been really committed to having young investigators on our study committees, and because the translational laboratory scientist who also does clinical work is a little bit of a vanishing breed, we've recently come up with a new strategy to try to promote the careers of those folks as well. So that was a lot. I'll stop here. There's a jillion people to thank. I can't possibly put them all on this slide, but I've listed some of the groups that really do the work.
Thank you, Dr. Bagatell. Gavin, because we have a microphone up there, if you could call and talk.
So, Ro, first off, thank you for a great presentation, and thank you for your leadership of the Neuroblastoma Committee. We're really lucky to have you.
Thanks.
Two questions about 1531 timelines. First, when can ALK-mutated patients expect Arm E to reopen? And I'm assuming that since 1531 is closed, that will be in the context of a different study. And then second, given the clinical urgency of the treatment questions explored in 1531, can you help us understand why it takes almost 2 years to analyze and release the study findings? I think you said October 26th is the target.
Yeah.
And maybe these questions can be viewed in the context of your kind references to patients sort of pushing you guys a little bit. Because I think, again, that timeline seems a little bit long for patients who are, waiting to see what the best treatment outcomes are from the study. Thank you.
Yeah, but super good questions. I'll take the first one first. There were a lot of very frustrating delays with getting Arm E of ANBL 1531 reopened. That will reopen. So the main randomization on 1531 is closed, and it's closed for good. But Arm E will reopen, and patients from ANBL 2131 whose tumors harbor an ALK aberration will get shifted over to 1531, and we'll finish out the number of patients that we need on that, so they'll get added together rather than starting a whole new trial. We in the COG have been prepared and ready to do that for a very long time, but because there's a lot of oversight of what we do by our funding agencies, and there were some concerns about reopening it, we just had to go through the process of getting it reopened. Very frustrating. But we've done it. ANBL, the amendment to allow ANBL 1531 to receive patients has been fully approved. We're ready. The amendment to ANBL 2131 has gone through the NCI and been approved, and we're just waiting for the Central Institutional Review Board, or CIRB, to also approve it. So I want it yesterday, or I actually wanted it last year, but
2025?
yeah. So that's good. And there are just some unavoidable delays, like, I can't say any more about that. Anyways, but speaking of unavoidable delays, let me talk just for a moment, indulge me, about trial design. So when we look at outcomes in children with neuroblastoma, we look at event-free and overall survival. So event-free survival is survival without relapse primarily. Overall survival is whether you're alive or you're not alive. We in the COG use event-free survival as our endpoint rather than overall survival because, as you know, there are many, many treatments that have been developed for children with relapsed neuroblastoma that help them live for a very long time. So if we waited around for overall survival as a definitive endpoint, we'd be waiting for way longer than 2026. So we've focused on event-free survival. But you have to give patients time to have their event. So the very first patient that enrolled on ANBL 1531 enrolled on May 9th, 2018. I remember because it was my daughter's birthday. The last patient to enroll on ANBL 1531 was in October of 2023. If you start to look at event-free survival for the patient from 2018 and the patient from 2023 at the same time, the earlier patients have had a lot more time to develop a relapse than that kid who just enrolled last week. And so you have to wait for the last patients to get through therapy, come off therapy, and wait and see if they relapse. So there's a certain amount of time that's baked in. You have to wait for a couple years to go by before you can report 2-year event-free survival or 3-year event-free survival. It's completely maddening. I don't have the results, I won't have the results, and there's nothing we can do until that bake time has been completed. So the only thing we can do to kind of address that fundamental problem is to leapfrog. And so when 1531 closed, we opened 2131. When 2131 closed, we're opening 2431. You may be thinking, well, wait, what if 2131 is super successful? What if 1531 is super successful? If MIBG works, now we've done this study 2131 that doesn't include MIBG during induction. So now, what do we do with the results of 2131? So leapfrogging has some fundamental problems, but sitting on your hands and doing nothing has some fundamental problems too. So being the activists that we kind of are, we've come to accept the perils of leapfrogging in the interest of continuing to move forward. Does that address your question?
Thank you.
Yeah.
Can I just do a follow-up to that? You turn it off? Okay. Are there clinical design options with Bayesian statistics that would allow interim analysis, and then does that inform the leapfrog decision-making?
Yes. So we were able to, on 1531, I think I can go back to this. So it wasn't Bayesian per se, but we did have an arm dropping strategy on ANBL 1531. So based on the data that Gudrun presented from the European trial, Bumel as a conditioning for transplant was superior to CEM. And we in the COG said, that's fantastic. Let's see if we can get rid of back-to-back high-dose chemo with stem cell rescue, which is super toxic, and let's incorporate an arm that has Bumel into it and see if we can ditch and not be married to tandem transplant forever. And we designed the trial with an arm dropping strategy such that we would be looking at the data at certain time points and drop the loser. So the worst arm would come out. And in fact, sadly, to me and many others, the Bumel arm dropped out early. I don't know the numbers, they have not been revealed to us, but the Data Safety Monitoring Committee looked at the numbers and said, based on your statistical design, you drop this arm, which actually made accrual go faster because you're distributing the patients instead of to 3 arms to 2 arms. That's first grade. You know, what you're talking about, a truly Bayesian design, is like 3rd or 4th grade. And our overseers, that's a bad word, regulators were not willing to let us be that brave. We tried and proposed a much more aggressive Bayesian approach, and we got turned down. So. Yes, I think the regulators in 2015 were very different from the regulators in 2025. In our 2431 trial, the randomized transplant versus chemoimmunotherapy, we've proposed a hybrid trial where the arm doesn't necessarily have to be better if it's better or pretty close to the same, it's a hybrid superiority, non-inferiority trial, which I never thought would get through before, but the statisticians are a little more evolved, I would say, than before.
Hi. In light of all the cutbacks, has COG been impacted? And
Yes.
can
so-
can you indicate by what percent?
I don't know the percent yet, but there are a number of things. So funding to Canadian, so National Cancer Institute dollars that go to Canadian investigators have been cut fairly dramatically, which is a problem because those
Yeah.
Canadian investigators contribute a lot. There are also going to be big cutbacks to COG's budgets, the pain of which has not been fully said yet.
How do you see that impacting, let's just say, neuroblastoma research?
Enormously. So one of the biggest things is going to be the loss of young investigators. So the cutbacks on research funding to universities, medical centers, et cetera, is huge. So if you have a promising young investigator who's just getting their first grants and getting their lab off the ground, those are the first to go. And so you're basically cutting off your young people. And we have some amazing young people at my hospital at CHOP, and they're looking at the landscape and saying, why would I do this? Why would I make less money, work more, nights, weekends, write all these grants that are going to get refused when I could just go work for a drug company and make a lot more money?
You know, I asked that question of Dr. Donald Pinkel. I don't know if you know who he was. He opened St. Jude Hospital, and he's the one that achieved the first high cure rate for leukemia at 68 of 80%. He was a neighbor. And I asked him, why did you go into pediatrics? And he said, prior to that, he was telling me all his buddies were pounding on him, saying, why are you going into pediatrics? And because you're not going to make as much money. And his response was, that's not why I'm in the business.
It's true, but I think
I know, but
all of us who went into pediatric oncology, we could have made a lot more money doing something else. But I do think that we have to really prioritize our young investigators and find ways to encourage them to do the work that we all do going into the future.
Typically, what is I've heard the average time for clinical trials, well, it was 10 years. Is that kind of average for COG?
Yes.
Yeah.
So AMBL 1531, the trial gets its name from the time a concept is submitted to our funding agency. So ANBL 1531 was first proposed in 2015, and here we are, it's 2025.
In light of what you discussed about you need the event-free and overall survival, that's 5 years is what typically you're looking at for the
We've shortened it up.
event-free?
Yeah.
3 years now.
Yeah, 3.
So, but still, it's going out to 10 years. Is recruitment the issue that causes the trials to go to 10 years?
It's a little bit of everything.
Yeah, okay.
So there's some, like 1531, for example, went through its paces, getting all the different layers of review, which actually takes a couple years. There was some time where we had to work out some contract issues that involved the FDA and insurance providers and other things that took another year. It's all the things. And that's why we feel so strongly about this leapfrog approach, because we can't sit around and wait. The gestation time is painful.
The 2 years, to me, as a parent, seems ridiculous.
To me as well, I'm with you.
Okay. I have a daughter who's been fighting neuroblastoma for a long time, so is there anything that could be done about that?
About that, just like the review process?
Yeah, a lot of this, yes.
We're trying as hard as
It's
we
a political thing. too.
Well, I think that there's a lot of oversight. Now,
Yeah.
the Europeans have a different system where they put through a trial through many, many countries, and then the countries slowly adopt it and put it through their regulatory bodies. They have a long ramp-up time for their enrollment, whereas we open at 225 centers like
Right.
that. So it's a different model. They also have a model where they can, I love this about the European trials, where they can ask a new question by doing an amendment rather than having a new trial. There are some issues with that as well. So there's no perfect system. I drive the COG operations people absolutely crazy. When they see an email from me, I know they roll their eyes. Because
Good, thank you.
because I want everything done yesterday. When they send me a protocol to review, like a long hundreds of pages document, I send it back the next day. Like there is no sitting around. And I always want them to go faster, faster, faster. And sometimes they have to tell me, like, you need to stop. Doug Hawkins says it to me on a regular basis, like there are other diseases in the COG. Neuroblastoma is not the only one. I appreciate that children have leukemia, and that's a terrible disease too. I appreciate that there's a lot more going on in the COG, but I'm happy to have Doug scold me. Very happy to be scolded. And I will continue to advocate. I don't always win. I will tell you that. And I think the ARM-E amendment is a perfect example. We've been agitating and agitating for that ARM-E amendment for a long time, and it's like banging your head against the wall. Through neither Doug Hawkins nor anybody else is trying to prevent cancer research from going forward. It's just there's systems things that are just really hard to get through.
Thank you very much, Doctor.
A couple questions. Wendy, you're gonna. Oh, okay. One more. Go ahead.
I had a question about the MFBG imaging technology. We had heard that there was some supply shortages. I don't know if you could speak to that. And then do you anticipate that becoming the standard of care for scanning, and when you would think that would be
That's
taking place?
an excellent question. You're right on the money. So there have been some supply issues. The company that makes it is a little bit resource limited. And up till now, at least on the NANT study, they were mainly able to supply to the coast. We have just had a meeting with them recently, and they can now supply to other places in the country, but not everywhere. So I do think we'll be able to run this trial, and I do think we'll be able to enroll patients on it, but supply is a big issue for sure. Your other question was, do I think it'll become the standard? I hope so. I mean, it's 10-minute scan, no thyroid protection, images are beautiful. I would really love to stop doing MIVGs.
And would that be like several years out before that happened, if so?
I think so. The company needs to they're trying to get FDA approval in other indications. If they don't get FDA approval in adult neuroendocrine tumor, they're going to have some big financial problems. That's even in addition to the scope of the research that we're trying to do. So a lot of what goes on in adult oncology actually impacts pediatric oncology in ways that might not be obvious.
Thank you.
That'll be it. Okay. Thank you, Dr. Bagatell.